really in a meeting and I can't help it, but I really try to be respectful of your time. Ready? All right. So we're going to get started. Thank you for coming to the Health and Government Operations Committee. Our members will be coming in. If you see them getting up, it's not meant to be disrespectful. Is that they also have bills in other committees where they have to testify, but they'll come back. Okay, so if you see us get up and go, that's what it means. So we really appreciate you. Good afternoon and welcome to this briefing for the House Health and Government Operations Committee. This is our first session back in person since 2020. So I ask for your patience if we encounter any technical or streaming issues. This briefing is being streamed on the Maryland General Assembly YouTube channel. Panelists will control the transition of the slides. Before this briefing, all members were emailed a copy of each presentation. And I want to thank the staff for being so wonderful and just really on their game. If you do not have these documents, please let the committee staff know and we will send you a copy. Please adhere to our usual committee rules of one question and one answer for the panel, not one question and one answer from each panelist. Please keep your questions brief. Remember that they are available for you offline. Please keep in mind this briefing is scheduled to conclude before 3 p.m. And immediately following this briefing, we will take a 15-minute break because we have a bill hearing. And the reason why we need a 15-minute break is because they need to get into another Zoom room. And last time I did not know, and I made it a little tough for them. So I learned my lesson, and we're going to give them the 15 minutes they need, okay? So just be patient. So I will announce a short break right after we're done. So today, the House Health and Government Operations Committee will hear briefings on long-term care from the Maryland Department of Aging and the Maryland Department of Health. We will then hear an introduction to the Prescription Drug Affordability Board. And we will begin with the Deputy Secretary for the Maryland Department of Aging, Ms. Hutchinson. Will you be so kind and come up? And if you have a panel, will you be so kind and bring them as well? And if you could, once you have a seat, introduce yourself to the committee. We really appreciate it. And for the committee members, again, if you have any bills that involve the Department of Aging, this is the department and the person that you contact. The same thing for the departments that are here today. If our members or myself put in a bill and we have not contacted you and it affects you, before you oppose it respectfully, if you can reach out to the members, sit down with our members. They're wonderful. They're going to treat you well. And just sit down with them and try to see if you can compromise and work it out, okay? So good afternoon.
Good afternoon, Delegate Menu-Malik and members of the House. The Maryland Department of Aging appreciates this opportunity to come before you today to talk about and to provide a primer on long-term care. I am Bernice Hutchinson, Deputy Secretary of the Maryland Department of Aging. And to my left is Stevan Ellis, who is the Maryland State Long-Term Care Ombudsman. I am going to turn the remarks over to Stevan to lead and to discuss our Maryland Long-Term Care Ombudsman Program.
Hi, good afternoon. Thank you so much for giving us the opportunity to speak with you today. Thank you, Chair Pena Melnick and Vice Chair Ariana Kelly and the rest of the delegates here today. It's very nice to be here with you. I'm Stevan Ellis. I'm the State Long-Term Care Ombudsman. Thank you very much for the introduction, Deputy Secretary. I represent and lead the Long-Term Care Ombudsman Program from the state of Maryland. And the Ombudsman Program is the advocacy program for long-term care residents. And in Maryland, that is nursing home and assisted living residents. We have over 50,000 folks that live in both settings that are there for rehab, but also many call it home for an undetermined period of time. The Ombudsman Program, again, provides person-centered advocacy. So if you're a resident in long-term care, it's about what you want, what outcome you expect. We have families that call us as well that have expectations, and we also work with families, residents, other interested parties as well to help improve the quality of life and quality of care in both settings. In Maryland, we have over 200 nursing homes and over 1,700 assisted living facilities. So I wanted to give you an idea of what long-term care looks like. In some states, by the way, the Ombudsman program does do home care ombudsman work, but in Maryland, we don't. I'm one of 53 state ombudsmen. Every state has one, and I'm one of 53. And we are a very close network. We work together on making sure that we're better informed, better trained, everything from individual advocacy to systemic issues. In Maryland, the way our program is structured, we have the State Ombudsman Office, which sits within the Department of Aging, and that's why I get to work with Bernice Hutchinson, the new secretary, and all the other staff at the Department of Aging. We have 19 local area agencies on aging, and there is an ombudsman program in every county. On the Eastern Shore, there are ombudsmen that serve multiple counties. So we have Upper Shore, Queen Anne's County, and Lower Shore. And Upper and Lower Shore have multiple counties, as you know. So I wanted you to see the structure. We're very blessed to have wonderful ombudsman staff. We have over 40 individuals that work in the ombudsman program that are paid. And some of those folks work part-time, others work full-time. So I wanted to give you an idea of what our staff looks like across the state. We also have volunteers. Unfortunately, because of many reasons, and I think you all will understand this, our volunteer numbers have decreased during the pandemic. I think you know people that have changed professions and decided to do other things. It's the same thing for our volunteers, so we're working on rebuilding our volunteer program. The authority of the Ombudsman program comes from federal and state law, but I wanted to let you know that it's under the Older Americans Act specifically, which is a federal law that is reauthorized every 4 years. And by the way, if anyone wants more information about anything that we have to say today, we're very happy to send it to you, so please let us know even after this meeting. We want to make sure you know what you need to know for yourselves and for your constituents. So in addition to providing advocacy, you're probably wondering, like, well, how do we do that? So we visit facilities on a regular basis. Again, all of the nursing homes get regular visits. We try to visit all the assisted livings as often as we can. Usually nursing home visits are at least monthly. Assisted livings, it depends on the jurisdiction. For instance, in Baltimore City, there are over 600 assisted livings in Baltimore City. And so we don't get to them quarterly, but we basically triage the need there. We do regular visits to see what life is like. So what kind of activities are happening? How is the food? Is it clean? You know, do people seem happy? Does it seem home-like, even in nursing homes? And so those are the types of things we do as far as our regular visits. We also do complaint visits. We handle any kind of complaint, everything from, I don't like the way my care is given, I don't like the food, I don't like the way I'm being treated, and we deal with any kind of complaint, and it's all about what that person wants. So if you want care given a certain way, then that's what we do. You'll hear from the Department of Health, I believe Office of Healthcare Quality may be speaking with you, and they'll talk about their role. We are not regulators, they are. So for us, it's about what do you really want, not what a minimum standard is. So that's sort of the difference, one of the differences in our two agencies. In addition to those visits and trying to resolve complaints, we do tons of education. So this is a wonderful opportunity. Today is an educational opportunity to let you all know what we do. We do education to anybody, to senior centers, to colleges, on conferences, to our peers. We really want people to know what our program is. And even more importantly than that, we want to let people know what long-term care is like for our residents in the state. So it's very important that we have these educational opportunities. We also train facility staff. We even train residents on how to advocate for themselves as well, so that's also really important about our role. We want to empower people to take care of things as much as possible, and so we do work a lot with residents, resident councils. We work a lot with family councils, which are groups of family members in facilities to talk about what life is like for their loved ones in long-term care. Sorry, there we go. So, our resolution is person-centered, and again, it is really what the resident wants. And I'm repeating that again because I think that's crucial. for you all to know. Just because you live in a facility doesn't mean you should not have the life that you want. And that's what our program is all about. We want to make sure that people who live in facilities have a good quality of life. I wanted to give you an idea a little bit about our data, just so you have a sense of that. I just submitted our federal reports, so I don't have that data officially finalized yet. I have to wait for the feds to look at that. But basically, this is preliminary. Last year, in fiscal year 21, we had 3,711 complaints that we addressed. In fiscal year 22, and by the way, our year is a federal year for the Ombudsman program, so it ends at the end of September. We had over 4,200 complaints. Our complaints went up. And the reason I believe those complaints went up is because we were visiting facilities more. There was a period of time during the height of the pandemic we stopped going in, and I think you all can understand why that would be. But we are back in going like we used to, and so we noticed at the end of this fiscal year that just ended in September that we were seeing more residents. Unfortunately, we were getting more complaints, but I think that's because more people were able to talk to us. Not everybody's able to talk to us on the phone, so being in person was critical, and so we were very glad to be able to do that. You might want to know what kind of complaints that we got, and it's interesting. For years, our source of complaints, our highest complaint was discharge, hands down. Discharge-related issues, everything from residents being asked to leave when they didn't want to leave, to the discharge planning not being prepared, families not being prepared, insurance issues, anything you can possibly imagine. My goodness, probably like you all, you think you've heard everything and then the phone rings, right? So it's the same thing for us. Well, what's happened since the pandemic for the last 3 fiscal years, including the one that just ended, care complaints have gone through the roof. And I'm very concerned about that. It has, and there's lots of reasons. And so what I do in my role as a state ombudsman, in addition to helping people with individual concerns, in addition to figuring out why a facility has the issues, it's also looking at the system. And I'm very concerned about probably many things you're concerned about in other areas, staffing. That is a very big concern, having enough staff, having well-trained staff, and when you don't have enough staff, residents suffer, and I'm very worried about that. So I just wanted to share that with you. So that's something that we're trying to work on as a program here in each of the counties, individual concerns, systemic issues, but then also as a program across the country. How do we deal with this issue? So I wanted to share that with you so that you know. The other issues we had were around discharges, resident rights, and abuse. Those were some of our bigger issues. Thankfully, abuse is not as high, but I think one allegation of abuse is too many. So we had over 200 allegations of abuse in fiscal year 22 that just ended. To summarize, I just want to let you all know our program is, again, resident-centered, resident-focused, all about what the resident wants. But we welcome people to reach out to us. We want people to know about our program, so I encourage you to share with your constituents, with people that you know. The more people that know that we're here for them. Our work is confidential, so if anybody calls us, we don't tell a soul. Our data is aggregate, so all the data that we have is aggregate, so no one will know it's about a specific place or a specific person. But I believe that's all I have to say for now. I really appreciate this opportunity, and I'll turn it over to Bernice Hutchinson.
Thank you so much, Stevan. So, having heard from Stevan, you have a snapshot, a primer, on one end of our continuum within the Department of Aging. I want to step back one spot from the Long-Term Care Ombudsman Program to give you a visual of a continuum that starts from the healthiest and the very well older adult, 60 and over, all the way across to the person who resides in a long-term care facility or an assisted living facility. The Maryland Department of Aging has the role of serving all. There are over 1.3 million adults 60 years of age and older in our state. And our programs are designed, as you've just heard about the Ombudsman program, to first and foremost educate. Second to educating, they are designed to inform through literature, through direct contact, and through options. And third, they are designed to connect people to services and programs, many of which we provide funding to do, but certainly many programs outside of our purview. And then finally, I think our programs are truly designed to ensure that the least of them, the most vulnerable, recognize the fact that they have every right to remain in their homes for as long as they choose to do so. And so with that, everything that we do at the department starts with the person. And you'll hear the term of art, person-centered. And that is our philosophy as well as our practice to ensure that people have the opportunity to tell us what it is they want and how they want it. And it is our role to ensure that we are not only listening, but doing the best within our program structure and our funding structure to connect them with services we have, whether they're inside of our purview or outside, and ensure the best communication possible that ensures their safety and their well-being. So now let's zero in to the step before you get to the nursing home or the assisted living facility. And our department has a range of programs and services and supports that we deem long-term services. The first, I'd like you to know that the state of Maryland was a leader among states across the nation to grab at an opportunity and to demonstrate as a pilot what we call the no wrong door system. And that system is all about taking our information and referral, where a person can call and say, what is the address of the Main Street Senior Center, all the way across to, I've been up 2 nights, my husband has beaten me, and I don't know where to go. You can imagine that's an incredible range for information and referral or information and assistance. But Maryland took the position more than a decade ago, almost 2 decades ago, to jump in and be one of the original states, the original 6 states, I believe, to look at the whole concept of a no wrong door. And now what we have in Maryland is called a Maryland Access Point. It's a system of not just information and referral or information and assistance, but it also looks at that full range, and it allows the person to express needs and desires that may be very complex. And through screening and through assessment, we're able to, in many instances, develop an options counseling plan, which may involve the Department of Aging programs and sometimes programs outside of it, to achieve the goals that are jointly established by the individual and the information and assistance specialist, the options counseling specialist. We assess, we prioritize, we ensure person-centered approaches and safety through the programs, first and foremost. But the no wrong door is so much bigger than that because it connects us not just to a service delivery system that's led through our infrastructure of 19 area agencies on aging that represent 23 counties in the city of Baltimore, but it connects us to other state-level departments, the Department of Health, and other entities to ensure that we're not only working in close partnership, but that we are receiving funds and working collaboratively through memoranda of understanding to serve this very unique population that is just a step away from long-term care facility or assisted living. And through the partnerships that we have at the state level, we join with 211, and we have a partnership for answering our phones that allows us to pull into a very detailed database of information and assistance for persons with disabilities, older adults, and caregivers. And this is what sets us apart from a number of systems around the country. We do integrate into that human services general approach to hearing what the concerns are, and we make sure that we're referring back. Many of those calls come directly to us, but others go to other agencies, state and local, across the state. The MAP system is one that we couldn't do it without you and your connection to your constituents, to let them know that the first point of entry into our system, if you don't know where to go, start with MAP. Start with a phone call, start with an email, start with that connection to get the direction. And oftentimes, there are those processes that allow you to get the assessment and the support needed. Now, a tier below will be specific programs, as I mentioned, that we work in partnership to ensure that we are looking at veterans through their self-directed programs coming out of the Veterans Administration. We also look at a whole plethora of vulnerable older adult populations, subsets of the whole. And our work with Department of Health has been incredible to ensure that there's not only funding, but the opportunity to support people who want to come out of the hospital and come back into the community safely, people who want to come out of assisted living and nursing facilities to come back into the community and know that there is a way that they will be reintegrated safely. So through that options counseling, you may hear the term money following the person, MFP. And just know that a lot of the focus of our long-term services component in the Department of Aging is to ensure that if people are institutionalized but want to come back into the community, that there are programs that exist that support that. So our long-term services and supports is recognized by vulnerable population. There are a range of subgroups within the older adult population that we focus on, but it is always, always about keeping people in the place that they feel safest and most passionate about. And we continue to hear through national surveys and through state surveys that people want to remain at home. And so that's the goal of our long-term services, first starting with information, then through the supports of a range of state-funded and federally funded programs to do so. And I hope that gives you just a very highlight primer. There is more information that if you would like us to send you on data points and descriptors of the specific programs, we're so happy to support you with that. We look forward to a relationship with each and every one of you to ensure that you are not only promoting our department and the services, but that you feel comfortable with doing that and knowing how it operates. I just want to close with just a little bit of a personalization. As I look around the room, I do see a couple of familiar names and faces, and I know that you're aware of the fact that if you don't know where to turn, our department is here to speak with you, talk you through, walk you through, and to ensure that if there's a problem with an individual or a group, we stand ready to work with you and to support your efforts to stand tall and say, we have a Maryland Department of Aging. So thank you for this opportunity. We're grateful, and we are looking forward to working with you. Thank you.
Thank you for being here. We appreciate your work. I usually wait to the end to ask questions, but I'm going to ask this one today. Actually, a suggestion, will you be so kind and put together a list of all the ombudsmen for different areas and their phone number? And will you be so kind and put together a list of all the resources and programs that our members, as they have problems, and I know my office has had, opportunities to help people in our district and connect them to you. What kind of services do you provide? If you could have someone put that together, sort of like a 101 little handbook that we can, have on our desk and we know we can call you, that will help tremendously all of us as we represent and do this job. We do have questions, and I'm going to start on my left first with Delegate Bandari, followed by Delegate Rosenberg.
Thank you, Madam Chair, and thank you, Undersecretary, for a wonderful presentation. I know you highlighted, however, what lessons have been learned from the pandemic concerning the delivery of long-term care services, and how will they inform future planning and preparation? And how is the state working with long-term care providers to address the mental health needs of residents and staff during and after the pandemic?
Did not hear the first part of your question. I'm so sorry. It did not come through. Can you repeat it in its entirety?
Yeah, what lessons have been learned from the pandemic concerning the delivery of long-term care services, and how will they inform future planning and preparation?
Yes, thank you so much. We've learned a tremendous amount from the pandemic. Our first kind of visual of that was that people ran home and took shelter. That affected our meals program, our nutrition services program tremendously as people left our senior centers and our community-based programs. But for long-term services, what we learned is that no matter how active and engaged, we have to look at social isolation more. It existed before the pandemic, but during the pandemic, we all became hyper-focused at what is the health and the mental health of our population, and how can we do a better job of reinforcing positive and good messages, but also services that focus on ensuring that isolation is not overlooked. And a person can be in the community and active and socially isolated. I just want to put that in there. So moving forward with our role and what we do around mental health, whether it is behavioral or cognitive health, we know that there is much work to be done, and we look forward to working with our Maryland Department of Health and with you all to think through as the numbers rise and more information becomes public about the struggles with mental health. I think we all want to recognize the role of medication management, the role of cognitive decline, and the role of mental health illness, behavioral health illnesses, and all of those having a role in how we move forward to ensure that we not only have programs that are sensitive and that there's training at every juncture to support the populations, but that we are also assessing what we have on the ground and where we can best utilize the funds and create new opportunities to address the growing number of people with cognitive decline as well as behavioral health issues. I think that the conversation must include those two components, and I believe that the conversation cannot be had about the effects of and what's needed to medically manage older adults in order to make sure that they are safe and thriving where they are.
Thank you. Delegate Rosenberg.
Thank you, Madam Chair. When you become aware of a systemic problem, how do you address that? What's the process?
When you say systemic, can you explain that a little more?
That this is something that's happening not just to this individual, but to others in too high a number.
Thank you for that clarification. I think it's our role at the Department of Aging, and it has certainly been our practice, to reach out to internally to our staff, to take a look at the data. The MAP data tells a story in and of itself. When people start to call us, we can look at the numbers and see where the needs are. And that's one lens, but there are other indicators within the programs that we fund. We gather that information internally, we have discussions, we talk it out, we walk it out. Then we reach to our state partners. We reach to the Maryland Department of Health. We reach to the other departments at the cabinet level. And again, we start that dialogue, or we look at what they have in place. What are points that we can shore up? What are ways that we can work together? We execute memoranda of understanding. And then we even go further to work with other organizations that are at the state as well as the community level, again, informing those partnerships, and also recognize ways in which funding might be provided to support some of the new or emerging systemic issues.
My vice chair.
Thank you, Madam Chairman. And thank you both for being here. I think, my personal opinion, no one's doing more important work in state government than you guys. Thank you for what you do. And everybody in state government does important work, but I have a soft spot. So my question is actually, I think, directly related to how you just ended your answer to Delegate Rosenberg's question. I am really concerned about financing for long-term care, and particularly, I know that state employees, we dumped our long-term care insurance plan. It doesn't work. The feds are freezing their long-term care insurance. What are the answers, and what are some of the gaps in financing for folks who are not wealthy, but not necessarily Medicaid eligible? What do we see in the future? What do we need to be doing? What do we need to be looking at so that people can get exactly the care you were talking about, in the way that they're looking for their care to meet their needs? I know, my grandmother had dementia, my father has dementia. It's more than $10,000 a month for that care. It's not something that folks who aren't wealthy can afford. How do we as a state begin to address that, and what kinds of systemic problems are you seeing in that space that we should be looking at?
So our focus has been in the past towards educating and towards doing the outreach. Our state health insurance assistance program is what I would call the boots on the ground that are steering people to making informed decisions about what's out there currently, and ensuring that people are not privy or prey to fraud and abuse in their insurance decisions. But what you're talking about is a higher level conversation about systems development and how our state moves forward. And I think that there is an opportunity for us to speak further with you about the way in which our department engages, not just with other departments at the cabinet level, but with you, and how we want to move forward. I know that we're right in the middle of legislative season, legislative session, and this is what a quick moving time period this is. So often we get legislation that comes before us, and it really should not be about support it or kill it. It should very much be about the things that we should be moving forward in a very constructive and meaningful way across the year to think about together how we're going to come up with solutions. So I would say to that, this is something that should be high on our radar. But I did want to give you that kind of boots on the ground, that we do have an effective and an excellent program around helping people to navigate what's already out there. But we've got a mile-high task, as you've so well expressed. A lot of room for us to tackle that.
Thank you for that thoughtful answer, and I know I've spoken with the chairman, and she agrees that looking at long-term care financing is something we want to prioritize and work on over the interim with the committee, so thank you so much.
Absolutely, and if after session, if you will be so kind and get in touch with my staff, and we can set up a meeting with the vice chair, myself, and the other chairmans of the committee and staff, so that we can think of a long-term plan. That'll be great. Are there any other questions? Seeing none, I want to thank you for being with us today. We really do appreciate your work. And may I ask, when can we expect that list that I requested?
I think you've requested more than a list. You've requested a welcome packet, and we are so delighted to provide that to you, so we can get that list to you quick, fast, and in a hurry. But like what I want to say to you is we want to follow up with a welcome package, which we hope you will not only enjoy, but that you'll read and recognize that we're here for you.
Absolutely.
Okay.
It's important because you spend a lot of time, I know our staff do, trying to figure out who to call to take care of this problem, that problem. So I want to make it as easy as possible for my members. So I thank you for being a partner, okay?
Always reach out, for my program, you can reach out to me anytime you want. Many of you have. I mean, I've talked to several of you, many times, and so I'm happy if you can always reach out to me directly. But I definitely can get you my staff list within 24 hours.
That sounds wonderful.
Yeah.
And if you could send it to our committee counsel for these issues is the attorney, Lisa Simpson, and send it to the whole committee as well. And thank you so much. We really appreciate you. Take care. I appreciate you. And you could take a few days if you need. Okay, thank you. Take your time. You could give it to us by the end of next week, okay? Thank you. My pleasure. You're welcome. Next, we have the Maryland Department of Health, and we have the acting Medicaid director. We also have the executive director of the Office of Healthcare Quality. Will you both be so kind? And I know I do not know you, Ms. Right? Tricia, do I know you? She probably has nightmares about me. Go ahead.
I've been in person, so it's good to see you all again. Chair Pena-Melnick and Vice Chair Kelly and other members of the Health, Government, and Operations Committee. I am delighted to be here, as well as Tricia Ney, who's our Executive Director for the Office of Healthcare Quality. You gave me a laudable task to give you a long-term care 101 for Medicaid in a very short period of time. I will give a high-level overview, and of course, I'm sure you're going to have questions. I'm also coming back next week to give you a broader Medicaid 101. But again, today I'm just focusing on long-term care within Medicaid. I'll go first, and then I'll hand it over to Trish Ney. Let me just make sure I'm working this right. Great. So generally in Maryland Medicaid and across the country, you become eligible for long-term care services through 6 eligibility categories. So basically, if you're age blind or disabled and you're receiving supplemental security income, SSI, you are automatically enrolled into Medicaid. There's an opportunity to become eligible for Medicaid if you're in nursing homes and receiving services. You also, in Maryland, there's some optional waiver programs that we operate that provide home and community-based services for individuals who meet a certain medical level of care. We also have a program called Increased Community Services Program, and so essentially this program, if you imagine, if you're on a home and community-based waiver, and for some reason you have a slight increase in income, we don't disenroll you from that program. We try to keep you on that program again to just protect you from a slight change in your income. And then, of course, we operate a PACE program. It's called the Program of All-Inclusive Care for the Elderly. This is a capitated program, and what's unique about this is it provides and integrates the services that you would receive in Medicaid as well as Medicare. And I'll talk a little bit more about that in my later in the presentation. Right now, we only have one PACE operator, and that's through Johns Hopkins. But we're looking to expand that program. And then, of course, low-income Medicare recipients have the opportunity to have their premiums and cost sharing covered by Medicaid. So there won't be, for certain low-income Medicare recipients, they won't have any copays or deductibles or premiums. I know all of you have heard about the Affordable Care Act and the expansion that happened under the Affordable Care Act, that now working adults and families, it expanded those groups up to 138% of the federal poverty level. You probably also heard that those populations no longer have an asset requirement. That is not true of our long-term care eligibility groups. They have both an income test as well as an asset test. And I've listed those across the different programs. So for example, nursing homes, we serve individuals up to 300% of SSI, but they do have to, the unique issue with nursing homes is that you can have high income and still qualify for Medicaid, but those excess resources we require you to pay for a portion of your care in the nursing home. So that's typically called, you hear a contribution or a spend down group within a nursing facility. The home and community-based waivers, which I touched upon on the earlier slide, these are optional waivers, and we tend to serve up to a higher income level under those waivers, 300% of SSI. Again, increased community services, similar PACE, similar income threshold, 300% of SSI. And then, as I mentioned, SSI, you're automatically enrolled into Medicaid in Maryland, and that's roughly 74% of the federal poverty level. And again, there is an asset requirement for all of these categories. As you heard earlier from the Department of Aging, one of the goals and policy goals across the country and in Maryland is to serve less people in nursing homes and to serve more people in the community. Again, we want to do it when it's the person's choice and it's safe for the individual. And so you can see sort of our trends in terms of nursing home and the community-based services. Again, this is a little bit skewed because of the pandemic. There was underutilization of nursing homes that happened just because of the pandemic, and of course an increase in community services through the pandemic as we were trying to reach more individuals. So what has allowed us to serve people more in the community? There's a couple of programs that there are no wait list attached to it. These are personal assistance services. And with that, in order to receive those services, you have to need at least help with one activities of daily living. And then Community First Choice goes a bit further, and the benefit package is a little bit larger. You have to meet an institutional level of care. Medical day care, again, you have to meet a nursing home level of care to qualify. For all three of these services, though, there is no wait list or registry attached to it. And then, of course, the last one is the home and community-based waivers. And I know the type is small, but we operate a number of programs. And generally, the concept is the same under home and community-based waiver. We serve a higher level of income, generally around 300% of SSI. You have to meet a certain level of care, meaning you would qualify to receive services in a nursing home, a hospital, or intermediate care facility for individuals with intellectual disabilities. So you have to meet that level of care, and the concept is if we can make your service plan or care plan budget neutral, meaning it can't cost any more than it would have cost in the community, in the nursing home or the hospital, we can provide services in the community for you. Again, because it's a higher income level, we cap those programs. So we apply to the federal government to serve a certain number of individuals. And when we hit that cap, we have wait lists or registries. And I know you've heard about our wait lists and registries before. The one that's most popular is the community options waiver, and that's the wait list is around 24,000 right now. Again, as I mentioned, the personal assistance services, there's the community first choice, the community options waiver, and then medical day waiver. And I gave you, this chart sort of shows the benefits that are offered under those programs. Again, as you move from community personal assistance services to community first choice, you receive additional services. And again, the bar to receive services under personal assistance services is much lower than when you move to community first choice, and so on. Medical day care waiver, you can also receive community first choice services, so you can be in both programs at the same time. Again, just showing you some of the recent trends in these programs across the year in terms of how many people we're serving. Community first choice, the trend is going up. The community-based options waiver, which I just talked about, we have lost a little traction in that program. Personal assistance services has been going down, but that might make sense because community first choice has been going up. And medical day care has been going down some. I just want to remind everyone that we did close medical day centers during the pandemic, so that is definitely impacting these numbers. When we closed them down, we were giving additional services through community first choice, so we were still serving individuals, but that is definitely impacting these numbers that you're seeing right now. Again, the one that you hear most often is our community-based options program. And as of right now, the program is serving a little over 4,000. The population is 18 and older. And again, it serves both older people and individuals with disabilities. There was some concern with regards to how large our registry was in past years and is currently. And so we put in a process in 2019 so that we could prioritize those individuals. So we screen them and prioritize them so that we're serving the ones that need the most services, most urgently, as soon as possible. And then we still take into consideration the individuals who have been on the registry for a long period of time. So we prioritize based on need, 80% of the participants, and then, of course, 20% get weighted towards how long you've been on the registry. It's a fluid process, so as more people come onto the registry, that ranking changes. And again, you can see the various priority groups that you could be ranked in. Delegate Colson, we talked yesterday about House Bill 80, and we gave her an update of where we are with the legislation. So the legislation required us to apply to the federal government to expand the number of slots on the community options waiver. We have done that. And so you'll see through the time periods, the legislation required us to apply up to 7,500, and that will take into consideration the last year of our terms and conditions with CMS. Also, it required us to increase the number of applications that are sent out or invitations to apply to the waiver on a monthly basis. Right now, we're sending out 300, and it requires us to go up to 600. We had to work with our vendor, and we're working with them to make the system changes to send out those applications and that increased number. They're going to be testing the system, and they should be fully operational with increasing those invitations to apply by June of 2023. And then wanted to touch upon that there was legislation that passed last year as well that requires us to develop a plan to reduce the waivers that have a registry to 50% by 2028. We did just release that report. We apologize for it being late. And I know that there will be lots of questions when you take a look at it. There's some big numbers in there in terms of the cost. We talk about staffing, but one other thing that we'll have to be conscious of as we expand these waivers is just the provider network and making sure that we have care managers, enough care managers to serve these individuals. So we'll want to have thoughtful conversations with you about that report and potential future expansions. And then lastly, just good news, as I mentioned earlier, we are expanding PACE. Again, right now we currently just have one PACE provider, and we are looking to expand in three other sites. We went through a RFI with applicants, and so we expect 2 of them to be operational this year, and then the third one next year. So we're really excited about that program. It is a capital intense program, so it is definitely hard to expand it and to operate those facilities. So limiting to 3 is a big expansion in Maryland, and I'm really proud of the staff that worked on that. So with that, I am done with my piece, and I'm going to turn it over to Trish, and you just tell me to work the slides.
All right. Good afternoon. Thank you, Chair and Vice Chair and members of the committee. It's a pleasure to be back here in person again this year and to see familiar faces and the new faces. The Office of Healthcare Quality is that part of the Maryland Department of Health that oversees the quality of care, and now 19,885 providers in 45 different industries. Show the next slide. This is a laundry list of, in alphabetical order, of all the programs we oversee. And probably one of the most important things I'm going to say to you today is that if you go to the website and go to OHG, the tab that says programs, every program has a web page dedicated to it. And if you don't now, you will have a constituent that wants to file a complaint or get hold of our team. Every program page, bottom right-hand corner, says contact the team or file a complaint. So without even looking at these pages, your staff can tell the constituents, go to OHCQ, to programs, to their page, and go to the bottom right-hand corner, and that information is now just a single button away from them. You're going to see that in addition to healthcare facilities, you'd expect to see hospitals, nursing homes. You'll also see we oversee things like forensic labs, portable x-ray providers, major medical equipment companies, the tissue banks, and outpatient centers like where you go to get your blood drawn. OHCQ wears both a federal and a state hat, so let me explain the difference. Under the state authority through the Secretary of Health, I issue license. So I issue the license to allow a provider to operate that business in Maryland, and I do licensure surveys. Under my federal hat, on behalf of the Centers for Medicare and Medicaid Services, I do surveys for certification and recertification purposes. And once we recommend certification of a provider or a supplier to CMS, and that's approved and determined to be accepted, the recommendation by CMS, Tricia's shop gets notification that now she can pay them from Medicaid funds and CMS will pay Medicare funds. So while we aren't tied into the reimbursement system, our surveys are the basis for the certification of them. And we also provide technical assistance, but it's limited to either those licensure or certification activities. We're not permitted to be consultants, and we're not permitted to be educational. We just provide that technical assistance to help the providers with licensure and certification. So of all those 45 types, I'm going to focus on 2 in the long-term care continuum today. And the first is nursing homes, or you may hear us call them long-term care facilities. And our role is both licensure of those facilities as well as certification. What we do is we're going in unannounced to nursing homes across the state, and we're doing surveys to determine compliance with state and federal regulations. So if I see that they're not complying with something, I cite that noncompliance in a written report. And state and federal law then require in a certain number of days, they submit a plan that addresses that concern and they fix it. 2 other things we do you may not be familiar with is my office investigates allegations of GNA, geriatric nursing aid abuse in nursing homes, and we work closely with the Attorney General's office and recommend to the Board of Nursing when a GNA should be placed on that GNA nurse aid abuse registry. And we also have 2 full-time surveyors in our unit that survey at all facilities yearly looking at resident funds accounts in the nursing homes. So those residents of nursing homes have small amounts of money that they manage and use for purchases, and we're making sure the fiduciary responsibilities are met during those surveys. So nursinghomecompare.gov is a CMS website. Your staff should be familiar with this because it contains really important information for all stakeholders and the public, and you can find this all on their website. Every nursing home in Maryland and throughout the country and U.S. territories is included. It includes what you've heard, the 5-star rating. 5 is higher rated than the 1s. It includes information about nursing home staffing, which you've heard is very important. It has information on COVID-19 vaccination rates, on fire inspections. And if you want to know where all those reports I write each year are, you'll find them on this website. So all nursing home federal complaints are posted for the public on this website. Switching to the assisted living unit, they are not federally certified. They're state licensed, so my authority is through the state. We overlap with Tricia's shop with her Medicaid waiver team and work closely with them. Of the 1,700 plus assisted livings, I'm guessing 500-600 are currently Medicaid waiver providers that have additional requirements in addition to my licensure requirements. We go unannounced to these facilities and we cite noncompliance with the state regulations. We also, in this unit, investigate allegations of unlicensed assisted living facilities, and probably half of those come from members of the legislature whose their constituents think that something's being run down the street illegally because there seem to be different people living there and wheelchairs and vans showing up. So that's my team who investigates that. And we also approve Alzheimer's special care units in assisted livings throughout the state. This slide is looking at the assisted living programs, so about 1,700, and I broke it down by jurisdiction. You can see if we're simply looking at the number of programs, Baltimore City has the most. They have 402 licensed assisted livings, followed by Prince George's County. And on the next slide, you're going to see the bars shift here, because what we did on this slide is we looked at how many licensed beds there are in each facility, and we plotted where the licensed beds are located. You're going to see that now Montgomery County is nearly 5,000 of the licensed beds are in that county, and Baltimore County almost 4,400. What this shows you, though, is Prince George's and Baltimore City, that they have more assisted livings, but they have less licensed beds. So generally, smaller facilities in Montgomery County and Baltimore County tend to have the larger ones. And assisted living is 2 or more residents, and we have some that are over, I believe, 300 now, and there's no upper limit to the number of beds. If you want information on assisted living programs, you can find it both on the OHCQ website, and you also can find it on the Maryland Healthcare Commission's, which has an excellent section on long-term care services and providers and additional information. And in closing, I'm reminded of OHQ's mission. We're to protect the health and safety of Marylanders across the healthcare continuum and to ensure confidence in those systems. And I would propose that that's a common goal that all of you have. I think we're all here to protect the health and safety of Marylanders and make it a better system. So thank you for the opportunity to speak today.
Thank you for for being with us. We appreciate you both. Are there any questions for this panel? We have first Delegate Alston.
Madam Chair, I would like the opportunity to meet with you all about some of the issues. The first question, well, I have one question that I can ask. It's
Thank you.
I'd like you to elaborate, please, on what's being done to get that 24,000 wait list down. And I did receive a constituent concern about Medicare waiver patients being allowed to have keys to the homes if they're staying in an assisted living facility, and being allowed to eat what it is they want. If you could talk to the regulations on that. I know you can talk to me offline about it if needed, the latter. Thank you, Madam Chair.
Thank you.
So as I mentioned with Delegate Cullison's bill, we are increasing the number of invitations to apply from 300 to 600. That'll go into operations June of 2023, so this year. In addition, we applied to increase the number of slots, and then to 7,500. And then in addition, to account for the increase in applications, there are additional monies in our budget to cover those additional folks that we hope to be serving under the Community Options Program. And then lastly, as I mentioned, we did submit a report that just went out 2 days ago, and it does look at the costs associated with decreasing those registries and wait lists to 50%. I do think we need to have a thoughtful conversation around that, because you do have costs associated with the additional services, but you also have constraints around the provider network. CMS requires you to have a conflict-free case manager to all of these services, and there probably is not enough case managers to serve the increase in population. So I think we need to have some thoughtful conversations around any expansion.
Thank you.
My pleasure. Delegate Collison.
Thank you, Madam Chair. So this is for Dr. Ney. And thank you both. I appreciate, I know I can pick up the phone and talk to either one of you, so I truly appreciate that, and letting my new colleagues know that as well. But I understand you're working on updating the regulations for assisted living programs, and there's been some delays in it. Do you have a timeline for when those might be completed?
Sure. So we're reviewing the entire chapter. We're currently responding to over 300 comments, which will be posted on our website. The bulk of those are completed. We had meetings over the last several weeks with the AG's office to clarify what was statutory versus regulatory, so we're finishing off a very small number of those. So I would anticipate in the coming weeks to a month that those should be posted online. People have a chance to look at that, and they'll progress then.
So you think could it be as early as the end of the year, this year, to go through the whole process? Okay, great. Thank you.
I see no other questions, so I want to thank you both for, oh, actually, my vice chair, go ahead.
Sorry.
It's okay,
I'm
last
sorry.
minute, you got me, go ahead.
Well, your very nerdy vice chair was like trying to calculate math around the eligibility levels, and I wasn't fast enough, but I was trying to figure out. So I appreciate, again, same thing I said to the last panel. Thank you for the work that you all do. This is so important. I know that Trish Roddy was talking about sort of some of the differences. Sorry, I wrote it down. Between community first choice and the community options waiver. And I'm really interested in identifying, to get at the point of the question I had earlier, which is who are we losing, who do we need to work harder to help, in addition to the work that's being done to expand the community options waiver and the waitlist issue. But I would like to really drill down in terms of who is eligible for which program. So I think what I have been able to determine was that in order to be eligible for community first choice, we're talking about Medicaid eligible population. What's the income level for that? And then it's an expanded income level for the waivers. And what does that actually translate to in terms of if someone just has Social Security and they're just living on Social Security? What person is this, right? So I know you can answer the question. I'm going to tell you what I've best been able to figure out, right? Is that we have sort of the lowest income folks who are able to qualify for the community first choice. Slightly higher income folks, and again, we're talking about retirement income, folks who are out of the workforce and on some sort of Social Security. Maybe they have a small pension. Maybe over their lifetime they've been able to accumulate some assets. But a new world, right, where most people don't have pensions, lots of people don't have assets, and we're struggling. So I guess my question is, what's the difference in those income thresholds? And then who are we not catching in any of these programs because they're slightly above income eligibility? My rough math was like something like around $65,000 a year in a Social Security. If your income was around $65,000 a year, your Social Security payment would make you ineligible for either of those programs.
So essentially, I might not have all of the numbers in front of me, but slide 3, it shows what 300% of SSI is on a monthly basis. It's around $2,300. And then SSI is about 74% of FPL. So I think FPL, I want to say maybe it's like 14,000 around that for an individual. So 74% of that, it's pretty low. Again, Maryland automatically enrolls individuals who are on SSI into Medicaid. There's no other additional steps that you have to take. The community first choice and the personal assistance services is open to everyone who's on Medicaid. There's no there's no wait list, no registry, nothing. So everyone on SSI is eligible for those as long as they, again, meet the medical level of care requirements. So for community for community options, community first choice, you have to be nursing facility level of care. So again, no wait list for those. Again, for community options, there is a wait list. And again, the breadth of services is a little bit expanded on that. But again, if you're in community first choice, you can also get medical daycare. There's no wait list for medical daycare, so you can have a combination of the two. I hope that answers.
I think so. I think that I always turn off the mic. I'm so naughty. She's going to be glad when I'm gone. So just to be clear then, so that $2,300 a month, I think that's roughly related to what you would get in Social Security if your earnings were around $50,000 or $60,000 a year.
Well, and that number is 300% of SSI. So I think so.
Right. So, okay. So I did the math for like my $49,000 a year salary and what I expect to get in Social Security if only I ever had that and no other retirement savings, and I would be eligible for one of these waiver programs.
Yes.
But at a slightly higher income, I would not be eligible, nor would any of our constituents.
Right, and that is a limitation from CMS. Those waivers are, that's the upper level that we can cover individuals under those waivers. You're not eligible to go above.
Thank you. Any other questions? Seeing none, thank you so much for being with us today. We will be with you next week regarding Medicaid 101, and Medicaid is the state public insurance. There are about 1.7 million or so people on it, and it increased during COVID. It was like 1.3, and it went up more than 400,000 people. As you know, the state of emergency is ending, and it was announced this spring. So we need to figure out how to make sure that people are not dropped. And I know that you have been very busy doing that, so we expect to hear about that plan because that's so important. And consider us a partner as well, okay? See you next week. Thank you very much. For our members, we have a couple of members that are not here today. They're not feeling well, but they are watching from home. And they send their regards. Our last panel before we take the 15-minute break for our hearing is actually the Prescription Drug Affordability Board, and we have Mr. Andrew York, who's the executive director, who's going to tell us a 101, very simple, what it is, what it does, and why we have it, correct? And I want to take a second to thank Delegate Collison, who has been a real leader regarding this issue, and a lot of the advocates that are in here today, like Benny, they were actually responsible and helped make this possible. And I know, Lisa, you lost a lot of sleep over this one, too. So good afternoon, sir.
Thank you so much, Madam Vice Chair and members of the committee. Thank you for the opportunity to talk to you today. My name is Andrew York, and I'm the Executive Director of the Maryland Prescription Drug Affordability Board. And we are just going to provide a quick introduction of our work for you this afternoon. So we were created in 2019, and we are an independent agency, and we are the first in the nation Prescription Drug Affordability Board. And our purpose, is referenced in our legislation, is to protect state residents, state and local governments, commercial health plans, healthcare providers, pharmacies licensed in the state, and other stakeholders within the healthcare system from the high costs of prescription drugs. We are a 5-member board. We have our chair, who is appointed by the Senate President and the Speaker of the House. That's Mr. Van Mitchell. We have Dr. Joe Levy, appointed by the Governor's Office. We have a vacant position from the Senate President. We have Dr. Abiria Nukuga, appointed from the Speaker of the House, and then Dr. Jerry Anderson, appointed by the Attorney General. And I would just like to say that we are very lucky to have the members that have been selected. They're all national leaders in drug pricing, and one of the real strengths of our board is the members that you've been able to put on there. We also have a stakeholder council, which provides advisory support to the board. They provide input to the board and then serve in an advisory role for certain studies and reports. They help us adopt regulations. And then the board also may give them specific things to do additional research on. So it's a 26-member stakeholder council. It represents all parts of the prescription drug supply chain. I'll briefly go through this. They serve 3-year terms. And again, they serve in this advisory role. So this is mainly for your reference. I'm not going to go through each of the members, but feel free to look through. And also, they're split between appointees from the Governor's Office, the President's Office, and the Speaker of the House. In terms of what the board actually does and what our authority is, we can conduct studies and prepare reports. We collect and acquire drug pricing and claims data. We identify drug products that meet certain statutory thresholds that may cause affordability challenges. We can do affordability reviews or cost reviews that I'll go over in just a moment. We also can request certain data that will allow us to do our work. And then finally, as part of the supply chain report, the board was able to determine whether it was in the interest of the state to move forward with something called the Upper Payment Limit Action Plan. So I'll talk about that in just a moment. So a lot of our work up to this point has just been kind of laying the groundwork of understanding the issues in the supply chain. I may get into this a little bit, but it's an extremely complex system. And I think that's one of the biggest challenges that we have is just understanding what the fundamental drivers are that are causing these affordability challenges. And the punchline is basically that there's a bunch of them. There is no one specific issue. So it's a number of different levers and considerations that we need to take into account. So we worked very closely with the Maryland Healthcare Commission, and we contracted with the Hilltop Institute. You may be familiar with them. They do a lot of work with our state and very exceptional analytical minds within that shop. And the first thing we did was develop a methodology to try to implement the legislative metrics that were given to us as part of this legislation. So basically, we need to identify all the drugs that have a launch list price of $30,000 or more over the course of a year. Drugs that increase, name brand drugs that increase over $30,000 over the course of a year. Biosimilars, I can provide details on that if that's helpful, but basically biologic generics that are not 15% lower than the reference price, and then generic drugs that are $100 for a 30-day supply and experience a 200% increase. So big mouthful there, but basically this creates the list of drugs that theoretically may cause affordability challenges. We had to do a lot of work to actually define what that means. It's easy enough to read this off, but when you actually try to pull that from the data, there's a lot of work that goes into that. So one of the first things we did was coming up with this methodology with the Hilltop Institute. We also can do cost reviews, and again, this is basically a deep dive on drugs that are causing these affordability challenges. So again, we have a list of, I think it's about 2,000 NDCs that are quote unquote eligible for cost reviews, and then we actually have to identify the drugs that we want to do a deeper dive on. And then we do a full analysis based on 10 different statutory factors that are in our legislation, and then we are ultimately going to make the determination of if they cause an affordability challenge or not. If they are found to cause that challenge, then basically, then you can pull a number of different policy levers to try to address that. Excuse me. We have a number of different reports that we provide. So I think one of the values that we provide is just a level of expertise, and we can do deep dives on very specific issues. We've produced 4 reports so far. One is a study of whether or not we can work with the Health Information Exchange to get additional prescription drug pricing data. One is a study of the generics drug market. Another is an annual report that you'll receive on general cost trends, the summary of our cost reviews that we do on drugs, and then any recommendations for legislation. So we'll have kind of annual recommendations for you. And then finally, we have a one-time study of the distribution and payment system, and then an analysis of potential policy options for the legislator. And this report is currently pending. This just briefly describes what was included in each of our reports. We basically found that we can continue to work with the Health Information Exchange team as an important data source. In terms of the generic drugs market, we generally found that the generic drug market is the market that currently works. Market forces do drive drug prices down. However, there's a few very specific issues, and those are generally the ones that you read in the news, of where this market fails. So there's definitely opportunities for us to work in the prescription drug market, or sorry, the generics drug market. In terms of our price trends, we'll publish that annually. This year we hadn't done any cost reviews yet, so our 2023 report will be the first year that we actually provide an analysis and review of the cost reviews that we do. And then we also have the general recommendations. In terms of our one-time study of the distribution and payment system. It basically looks at the supply chain. It also looks at the drivers of each what causes affordability problems in the prescription drug market. We've found that basically there's multiple markets that you're dealing with. So one is kind of the name brand small molecule market. Then you have the biosimilar or biologics market, the biosimilar market, and then the generics market. And then also a further differentiation is drugs that you fill in your pharmacy versus the drugs that are filled within a hospital or a physician's office that are generally administered by a physician. And then also there's a number of different issues within specific federal programs, Medicare versus Medicaid, the commercial market. We do a deep dive on each of those markets and where some of the flaws are there. And then we have general recommendations out of this report. The recommendations that came out of this report were one, to move forward with developing the upper payment limit action plan, and I'll talk about that in just a moment. The next is to develop a transparency program. One of the fundamental flaws that we found in this space is that there is no such thing as, quote unquote, the price of a drug. There's about a dozen different metrics that kind of refer to what a drug, what is paid for a drug, but none of those actually represent what's paid in the health system. So one of the first things we need to do is just actually understand where some of these challenges are, and that comes with transparency. So over the course of this year, we'll be working to do a deeper dive on that issue with our stakeholder council, get feedback from each of the different members in the supply chain, and then we'd likely have recommendations for legislation in 2024 for you based on that work. Next, we also recommended developing an insulin affordability program, and this is to supplement the copay caps that were passed by the General Assembly last year, as well as the Inflation Reduction Act copay caps for the Medicare market. There is still this group of uninsured or underinsured patients that may still have challenges. So this would potentially be a voluntary pilot program. I can talk through the different iterations of how that would work, but basically testing to see how we can do a wraparound service to capture those patients. And then also we're going to continue to study additional topics. So I would expect each year we can do a deeper dive into specific issues within the supply chain, either with feedback from the General Assembly or from our stakeholder council and board. So we'll continue to do deep dives on specific issues and come up with additional recommendations. Finally, we do have the authority, or had the authority, to do upper payment limits. There's a section in our law that basically allows us that if the board finds it's in the interest of the state to move forward with upper payment limits, they can develop an upper payment limit action plan, which would go before the Legislative Policy Committee for approval, and then we could start to implement those upper payment limits. Just in general, the upper payment limit is a very novel concept. Again, we were the first state in the country to propose this. A number of states have started to follow in our footsteps, and then there's also continuing efforts in other states to kind of follow our lead here. And so the work would be done through this upper payment limit action plan, where we would define, what drugs are eligible, what does it actually mean to set an upper payment limit, and then how you would actually implement that. You do have a hearing in just a few minutes after this on HB 279 that addresses a sunset provision that was in the legislation. So I think we can talk about that shortly, but did want to just flag that issue for you as part of this presentation. And then just in general, our ongoing work is we're going to be publishing this report on the distribution and payment system. We've completed our process for working through the kind of decision points for the cost review process. So we're going to be publishing those regulations in the spring, hopefully doing our first set of cost reviews by the end of this year. I can walk you through that timeline if it's helpful. We're continuing to work through our fee assessment. So we're funded through a assessment on different members of the supply chain, and that's kind of an iterative process as we stand that up. And then when authorized, we would complete our upper payment limit action plan. And then I did mention the other two programs that we kind of have as ongoing work. And then finally, we're always here as a resource for the members of the General Assembly. We live and breathe this, so we're always happy to kind of talk you through any of these complex issues. We have the opportunity to present to the Insurance and Pharmaceutical Subcommittee on the general distribution and supply chain, but I think one of the takeaways from that presentation is there are 5 other presentations that could have come out of that. So all to say, we are here for you and happy to help in any way that we can. So with that, happy to answer any questions.
And thank you for being available in the interim. I know we call on you many, many times, so thank you very much. Are there any questions for Mr. York? We're going to start first with Delegate Morgan, followed by Delegate Woods.
Thank you, Madam Chair. Hey, thank you for the presentation, Mr. York. It was informative. So at this time, has the Drug Affordability Board lowered a price on a single prescription drug?
Delegate Morgan, thank you for the question. So I would say that there is value in these boards in that they create the forum for discussion. Also, there's kind of just a general pressure on the market. And then a lot of our work up to this point has been kind of building the infrastructure to do our work. So we're an independent agency. We can talk through some general timeline issues, but I would say the real work hasn't basically started in 2021. So I would say the upper payment limits, when implemented, will lower drug costs. We have this insulin affordability wraparound program, which will absolutely help patients. And then also, one of the things that we're currently doing, and we're looking at opportunities to expand, is patients our Marylanders come to us when they can't afford their drugs. And basically, we can help them work through the very complex system to be able to afford their drugs, even just within the existing system. So I would say, and then one final thing is we do look forward to being the one agency that actually reduces the cost of the state versus increases spending. So, yeah, I think that's
Good,
Yep.
thank you, especially in the constituent work and following up with drugs. Just a real quick follow-up question. When you're anticipating releasing the list of upper payment limits later this year? Hit your microphone.
Excuse me. Yes, we would have to do an upper payment limit action plan, which basically lays out the process of how do you calculate the upper payment limit amount, and then how do you actually implement that. And then it would go before the Legislative Policy Committee. If approved by the Legislative Policy Committee, then it would be implemented through regulations. So,
Do you anticipate that being a large suite of drugs, or?
I think, I mean, I don't want to project on the board, it's ultimately their decision. Just in terms of the resources that it would take to do the analysis, I would picture a handful of drugs versus a large number of drugs that undergo a cost review, especially as we get started.
Okay.
And then you can also look at what Medicare is doing for their Inflation Reduction Act, and they're, talking in the terms of 10 drugs at a time. So I think that's, a realistic number versus, more than that.
Okay, thank you for answering questions. Thank you, Madam Chair.
My pleasure. We have Delegate Woods, followed by Delegate Rosenberg, then Delegate Lewis.
Thank you, Madam Chair. Thank you, Mr. York, for your presentation. I just wanted to clarify with regard to the upper payment limits. Are we saying that they are actually going to go into effect this year?
Pardon my use of the
okay.
microphone.
You don't have to touch it, just leave it. If you leave it alone, it'll come on.
Oh, okay, thank you.
It's okay.
So the timeline, we can build out the timeline, and there are a number of kind of milestones that need to be hit. So again, it's partially dependent on, one, when the plan is drafted, and I think that can be done in the spring if we have the authority to move forward with that. Then it goes before the Legislative Policy Committee. With that approval, if that approval happens, then it would go into regulation. So we would do proposed regulations and then final regulations. I think very aggressively, it could happen this year, but that is, again, a very aggressive schedule. But I think one thing I can say is the board is excited to move forward quickly with our work. Again, the past few years has kind of been building the infrastructure and staffing up and things like that. Now that we have that agency infrastructure there, I think we're kind of full steam ahead on implementing policies.
Thank you. Thank you, Madam Chair.
My pleasure. Delegate Rosenberg?
Mr. York, the federal government enacted the prescription review by Medicaid, Medicare. Does that have any effect on your work?
That's a great question. And I would actually say that one of the values of a prescription drug affordability board is being able to take advantage of the work that Medicare is doing. Medicare's drug negotiation is just for Medicare beneficiaries, which is 65 and older, and it's a very important patient population in Maryland, but then that leaves the rest of Marylanders that don't necessarily get to take advantage of the work that's done there. It all needs to be determined on how we would set these upper payment limits, but that could be a mechanism to kind of, build on the work that the federal government is doing, or making sure that other constituencies get to take advantage of that work. Go ahead.
Well, no, you go ahead, because I need the chairman's okay to go ahead.
Yeah, excuse me. So all to say that,
Thank you.
we were
I
very
really
excited to see.
appreciate the respect. Thank you.
Very excited to see that the Inflation Reduction Act had passed and is trying to address prescription drug prices. I think our process would be different, but it's all kind of the same general discussion and same general flavor. So we basically would be able to do on the state side what is happening at the federal side. So.
May I, Madam Chair?
Absolutely.
Thank you. Would this specifically apply to Medicaid, since that's half state?
Scope includes Medicaid, but it's a fundamentally different system. So I would say if we were to include Medicaid in our work, so they can certainly take advantage of our work, what they could do is take advantage of like the assessment of the drug that we do. But if they were setting the like upper payment limit amount, quote unquote, it's a different process for them. So they would probably use it you can look to two examples. There's the New York drug price cap and then the Massachusetts Health Policy Commission drug pricing review. Both of those are Medicaid programs that use a process that's probably comparable to what we would be able to do. And then they use that to negotiate additional supplemental rebates. And then also, because of the way that program works, the list of drugs that Medicaid cares about is just different than what the commercial market cares about. They have sometimes very substantial rebates to the Medicaid drug rebate program, so the drugs that they actually care about are just different. So all to say that we are a resource that's available to the Medicaid team. Our statute has that scope, but I don't think it'd be a separate process, basically.
Thank you.
Thank you. Delegate Lewis, followed by Delegate Chisholm.
Thank you, Madam Chair. Thank you, Mr. York, for the presentation, and thank you for leading the first in the nation Prescription Drug Affordability Board. We're really proud of the work you're doing. I recall that in 2019, we passed legislation creating the board, and I'm just wondering if you now have the resources you need to conduct your work. There was some issue with funds being released that slowed you down. Could you bring us up to speed?
Absolutely, yeah. So just in general timelines, our board was created in 2019. That legislation required that we come up with a funding source, which was subsequent legislation. That was passed in 2020, and that's the fee assessment that I was mentioning. So we're funded through a fee assessment on manufacturers, wholesalers, PBMs, and carriers or insurers. But that legislation was vetoed, so we were not able to basically have a funding source until that legislation was overridden, or the veto was overridden in 2021. So that's when I was hired as staff, and then we've been continuing to hire up staff over time. So I would say we have the resources now, and we've been putting our budgets in, and they've generally been fully funded out of the budget that's been produced. And then also, we are able to adjust our fee assessment as necessary to get the revenue that we need. So all to say, it definitely kind of slowed some of the work in the beginning, and I do think that kind of addresses some of the key timeline issues. But as of now, I think we feel very strongly and confident that we have the infrastructure and revenue and resources that we need moving forward.
Thank you, Madam Chair. If I might, just quick point of clarification. Sure. So the veto denied the board the resources that it needed to get started, but the veto override helped set up the conditions for the funds to start flowing.
There was legislation passed in 2020 that created our funding mechanism.
Thank you.
That was vetoed in 2020 and then overridden in 2021, so it went active. It became live in 21.
Thank you, Madam Chair. Thank you.
My pleasure. Delegate Chisholm.
Thank you, Madam Chair, and thank you, Mr. York, for the presentation. On the insulin affordability program, since we started talking about the federal government, President Trump signed an executive order 13937 making insulin capped at $35 for the copay, and then when the Biden administration came in, they eliminated that at the very beginning. Have you had any conversations or tried to contact anybody in the federal government to see if that could be reenacted so that maybe you don't have to reproduce a whole program, and if it was done on the federal government side, it would make things a little easier for you?
Thank you for that. Thank you for that question. So prior to working here at the state level, I had the opportunity to work at the federal level working on the drug pricing blueprint. So we learned a lot of lessons from the work that was done at the federal level. And the nice thing about prescription drug affordability is that it's a completely bipartisan issue. So I would say that we're certainly looking at those programs. Right now, the Inflation Reduction Act set the $35 copay cap for Medicare beneficiaries, but we would need additional legislation to do that beyond just the Medicare market. Luckily, in Maryland, we also had a copay cap that was passed last year that addresses basically the kind of some of the additional markets. And then we're looking at how we can make sure that anyone that is not protected by those two pieces of legislation can access their insulin. So you mentioned some Trump administration rules. There was actually a very impressive rule on insulin specifically, and that's one that we look to as a potential model for how we would do our program. So there's, this gets into the weeds, and please stop me if it does get too into the weeds. There's a few different ways you can do it. One is working with manufacturers to use their existing patient assistance program. So if you ask a manufacturer, they would say all patients should be able to access insulin, and they have programs that generally assist with that. But I think when you hear from patients, they can't access that. So one is potentially just partnering with manufacturers to make a more robust system there. The other one is kind of taking advantage of what that original rule was, which is working with certain facilities that get very deep discounts to drugs to pass those discounts on to patients specifically for insulin. That rule was, I think, I discontinued, but I think we can certainly look to that as an example. And a lot of our work is looking at as many ideas as there are out there and trying to find the best ones and bring them forward in Maryland.
Madam Chair, can I have my second question now?
The one from last week?
Yes, the one I banked.
Absolutely.
Well played.
Thank
My
you.
husband would tell you I have the mind of an elephant. Go ahead.
Thank you. Yeah. So I guess the overarching question, I mean, and I appreciate we're talking about a lot of programs, a lot of looking at things. In the perfect world, in your estimation, when would we see any sort of a savings passed on to the Maryland consumer?
So I would say, as early as tomorrow, if a patient comes to us and says they can't afford their drug, we help them through that process. Now, a lot of that, one of the challenges, and this is all of healthcare, not just prescription drugs, is it's just very difficult to navigate, and folks literally just don't even know what to do. So they may just be on the wrong drug, may not have the right insurance, may not know about patient assistance programs. An example I use is I always help my grandma find her Medicare Part D program, or her plan every year. It changes every year. It's very odd that you have to do that. And then also I find that confusing, and this is literally what I do all day, every day, right? So that's all to say that there's very low-hanging fruit that we can do starting tomorrow. For example, that insulin affordability program, when that's up and running, that's going to have a real impact on patients' lives. In terms of savings for example, through a policy like an upper payment limit, that generally has a longer time frame. I think we can give you timelines on specific policies. But then there's also just general things that, and another value of something like this board is you have a bunch of people that all they do is think about drug pricing. There's a lot of very low-hanging fruit just in terms of government contracts and stuff like that, where you can actually see very, very real savings. And those are all things that we're continuing to explore. Sometimes we just pass them on to our colleagues that can actually implement them tomorrow. So there's a lot of things that don't necessarily need, all they need is an eye and someone pointing out that, hey, this is like a gap. I think one thing we always hope to do is provide savings estimates with the work that we're doing. Again, our goal is to save the state more money than we take in or spend. So, we will have very real savings estimates, but there's also just a lot of general background work that we're doing that will find savings for the states that isn't directly attributable to quote unquote upper payment limits or something like that.
Thank you, Madam Chair.
My pleasure. Any other questions? Delegate Collison.
Thank you, Madam Chair. And thank you, Andy, for your work. It's tremendous. 2 years ago, we passed a bill that created a competitive marketplace for drug pricing in Maryland. Hasn't started yet. Lots of reasons, won't go there. But I'm anticipating that we're going to get this thing up and running within this year. So my question is, just for the purpose of quickly for the committee, what the competitive marketplace will do is define our contract, have the state define our contract instead of PBMs define our contract. And so we need information to define our contract. And then PBMs will compete for that specific contract. Do you believe the board will be of value to that process of defining our contract?
Thank you for the question, Delegate Collison. We are make ourselves available as a resource, and when referencing kind of just improved contracting and things like this. This is exactly the example. So I guess I need to put the caveat in that all members within the supply chain are acting exactly as the incentives provide. No one, I don't think we have bad actors here or anything like that, but the way that the system works, there's just a lot of loopholes. So that's all to say that this reverse auction process that you're referencing, I think is an important tool, but it's kind of it's not the complete portion. So what we are hoping to bring is flagging where some of these other loopholes are so that you can address that as part of the reverse auction process. So we are working very closely with our colleagues at DBM and DGS and hope to be a great resource for them. And we're impressed with their work. They're doing a great job.
Great, thank you.
Thank you. We have Delegate Bandari.
Thank you, Madam Chair, and thank you for a wonderful presentation. We're really proud of this board that we established in 2019. I guess the board has 5 members appointed by different authorities, right? And has advisory stakeholder council consisting of representatives from various organizations in the healthcare system. Could you share your experience working with those stakeholders and where are the roadblocks? And you talk about the methodology of identifying drugs that uses combination of metrics and additional criteria. Could you share your experience?
Thank you for the question. So I can just say that we're very lucky to have a very talented and knowledgeable stakeholder council. And I think it is very useful to make sure that we have everyone represented within the supply chain on that stakeholder council. They all kind of have a direct line to the board, and often they're kind of the sounding board as we work through a lot of these issues. So obviously, the big policy that folks are generally talk about is upper payment limits, when certain stakeholders will fall in certain places on that. Happy to provide details there if helpful. But again, we're looking at a number of different policies to generally just clean up the prescription drug market. And I think all stakeholders kind of play their part in that. So I think, as we continue to do our work and do our studies and make policy recommendations to our, executive branch colleagues and then also to the General Assembly, our goal is for everyone to be a little bit mad and not really mad, if that makes sense. So all these policies generally need to kind of work together. And yeah, so I guess just at a high level, very lucky to have a great stakeholder council. We have 2 co-chairs that are very exceptional. Mark Nicole from DBM and then Lorraine Diana, who represents the nurses. And yeah, it seems to be a very strong group. We've been meeting since March of last year, I believe. And we just appointed our co-chairs in the fall of last year. So we're really going to pick up and start to take advantage of the expertise that they have.
Thank you.
See no other questions. I just want to thank you for being with us today. Thank you for all the work you're doing. And on behalf of, every Marylander, and I have to say that the program that you're about to develop on the insulin, I think it's important because we did pass a cap that our members voted for here. However, there are people that do not have insurance, that cannot afford it, and I'm glad you're looking at that. Thank you so much. And this, for our committee, this will conclude the briefings for today. It is now 2:42. If we can come back at 3 o'clock, we will go into the bill hearing, Delegate Collison. This will give our staff some time to close this Zoom and open another window. Okay? Thank you for those that are watching at home. 15 minutes, 3 o'clock, please. Actually, a little more than 15 minutes, 18. Thank you. And there's food in the back if you like to get some food.